محمد. Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this evening where we are having another scientific gathering as a continuation of the previous one we had yesterday. And today we are going to shed light on the RSV burden in older adults. This is a collaborative medical education in association with the Saudi Society for Family and Community Medicine in collaborations with GSK company. So I would like to thank you for attending our sessions, and I hope this session will be quite fruitful for all of us. But before we start, I would like just to pave the way and to set up the stage by saying a statement which is very important for us because this is a family medicine and primary care gathering. All of us, we know that the healthcare system in the Kingdom of Saudi Arabia is getting transformed. And this is to reinforce a new concept, which is preventive medicine. Many years and many decades previously, we have been engaged totally to manage disease and to manage the complication of the disease and to rehabilitate those people who have some consequences as a complication of the disease. But now, in our new era of transformations, we are spending a lot of emphasis and a lot of interest in the management of patients in early stage of getting the disease. So that's why reinforcing the prevention is our target in this era of our practice. And this is in fact to improve the health status of our community and to reduce the financial burdens on the healthcare system. And as we know that we have implemented a very important concept, which is the value-based healthcare. Value-based healthcare means that we are providing high quality of care in a patient-centric approach with a clinical guidelines, so everyone speaks the same language of medicine across the board when we practice medicine, and then there is an outcome in terms of prevention of the disease or treating the disease or prevention of the complication minus the cost. So the cost effectiveness is the name of the game and the most important part of our efforts to optimize our resources. And of course, when we talk about the family medicine, it's the right fit for this kind of concept and to transform our healthcare system. So I think that our family medicine is supporting the transformation, reshaping the future. Why? Because of the easier accessibility of our service as a family physician and primary care. We are holistic and we are cost effectiveness, and we always all the time maintain the continuity of care. So we build a long-term relationship with our patient throughout the spectrum. So the best part of our family medicine scope of service is the prevention. And that's why we say, درهم وقاية خير من قنطار علاج. And this is what we are talking about today. And the best preventive tool that we have is the vaccinations and the vaccines against vaccine preventable disease. And this is, in fact, today when we are talking about acute lower respiratory tract or respiratory tract infections, we know that in 2013, 5 million of the population of the Kingdom of Saudi Arabia, they had an acute lower respiratory tract infections, which was a major health problems affecting almost 15% of our total populations. And it has been shown through different epidemiological studies that most of these infections are related to the virus. So the virus were responsible for majority of these problems. And this epidemiology and of respiratory viruses in Saudi Arabia was proposed. Why? Because we are a very unique country. We have the mobility of the large number of the foreign workers, and we have the gathering of the millions of Muslims in Mecca during the Hajj and Umrah region. And we have been privileged to be hosting this mass gathering of populations of Hajj and Umrah populations throughout the year. So the severe acute respiratory infections caused by different pathogens that we are countering nowadays in this kind of season, that we are encountering upper respiratory tract infections and even the lower, which is caused by influenza A and influenza B, respiratory syncytial virus, and the coronavirus. So this is the cocktail of the viruses that we are encountering during this stage. The RSV, as we know, in older adults, is the hidden annual epidemics. So that's why there is a lot of emphasis to identify those people at risk and to tackle the problems of the RSV, knowing that the clinical presentation of all these infections by all these viruses are indistinguishable. So, and most of the time we treat symptoms rather than there is a specific medication. So the best tool to use this kind of prevention is to use the vaccinations. And we are going to be privileged today to have certain objective to understand the burden of the RSV in older adults and what are the symptoms of these kind of infections and what are the timing of the infection incidence, what are the risk factors and the spread of the infections, and what are the measures to reduce the risk, and finally we'll be landing into the vaccination for the RSV. So with this kind of different items of our topic today, we are privileged today, ladies and gentlemen, to have our guest speaker, who is well known to in the medical community with his participation and his interest in education, Dr. Tarad Adnan Tilmisani. He is a consultant family medicine and geriatric, assistant professor of family medicine and geriatric in Al University. He obtained his American Fellowship in Geriatric from Oklahoma University, American Board of Family Medicine from Texas Tech University, and a Clinical Research Fellowship from George Washington University. And he's going to talk about respiratory syncytial virus, the burden of the disease in older adults and its prevention. But before we start, I would like just to say some housekeeping notes. So to earn your CMEs, ladies and gentlemen and colleagues, please register your Saudi Commission for Health Specialty registration number correctly, and try to put your questions in the Q&A box that we have it here. So at the end of the session, I'll be able to collect your questions and deliver it to Dr. Tarad. And we are going to have now, before we start, a pre and post event testing. So before I start, I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the vice president of the Saudi Society for Family and Community Medicine. I'm working in International Medical Center, and I've been practicing medicine for the past 30 years. So, so today we are going to have, this is my disclaimer, I'm not a GSK, and I would like to just to scan this QR code in order to have the questions. So we will have certain 4 or 5 questions, and you will be able to test your knowledge before we start. And the same QR will be presented at the end of the session. So we will be answering the questions once again, and we'll be able to identify how much valuable information we have gained through the presentations that have corrected many of our thoughts and data that we have. So if you have scanned the QR, we'll go for the first question. The first question is, respiratory syncytial virus infections may occur in upper respiratory tract, lower respiratory tract, lower digestive tract, upper and lower respiratory tract. I'll give you 30 seconds to answer it. Okay. The second question is, all of the following groups are at increased risk of severe illnesses due to respiratory syncytial virus infection, except older adults, especially those aged 60 years or older, healthy teenagers, people with chronic heart or lung disease, immune-compromised people. 30 seconds. The third question is true or false. So after full recovery from RSV infection, most individuals cannot get reinfection. Is it true or false? Next question, incidence rate ratio for RSV hospitalizations in older adults in COPD is compared to the healthy individual. Is it 2.3 to 3.6, 3.5 to 13.4, 3.7 to 6.75, and 4 to 7.6. The last question is incidence rate ratio for RSV hospitalization in older adults with congestive heart failure compared to healthy individual. Is it 2.3 to 3.6, 3.5 to 13.4, 3.7 to 6.5, 4 to 7.6? So with this, I would like to introduce or to ask Dr. Tarat to have his own way to the presentation. And I'm very sure that it's going to be very interesting for all of us. And it's a good learning opportunity to learn from Dr. Tarat's experience, especially when he's specialized in geriatrics and he's very, very much into countering, the geriatric populations in his day-to-day practice. So thank you, Dr. Tarat, for accepting the invitations, and I'm leaving the floor for you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ashraf.
So,
And just give me a second. I will open my presentation if you don't mind. Thank you.
I would like to welcome Dr. Muhammad Athanian, who's joining us. And it's a really privilege for us to have Dr. Muhammad. Dr. Muhammad Athanian, he's a preventive medicine specialist. He holds his degree from University of Michigan. He's part of the National EAPI team since 2016, managing the National Vaccination Coverage Unit. And we are going to have him with us here in the last session so we can have a chat and we can have some kind of Q&As and discussion regarding the RSV vaccination. Thank you, Dr. Muhammad, for joining us, and I will leave the floor for Dr. Tarat. Thank you.
Thank you, Muhammad. Can everyone see the screen or not yet?
No, still starting.
Okay. Okay, let me just double check on this. Still nothing?
No.
Okay. Okay.
You have a share screen, right?
Like troubleshoot the Zoom and return back. Is that okay?
Right, okay.
Okay, I'm just gonna need 1 minute and return back to the presentation. Thanks.
You can see it now. Maybe.
Okay, I think we can work with this.
Okay, yes, we can see it now. Yes, go ahead.
Thank you very much. بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. Good evening, everyone. Thank you all for being here tonight and giving me some of your precious time to join us tonight. I want to thank the Ministry of Health, the Saudi Society of Family Community Medicine, and GSK for giving me this honor to be talking to you all. As Dr. Ashraf Amir said, we're going to talk about pretty exciting things tonight. The reason is we're going to talk about an old disease, but in a totally different context. And as we all know, the vision of 2030 is all about advancing the preventive medicine and more of primary health care measures that we can apply. At the same time, the expected mortality rate to raise up from the 70s up to the 80s. So when I say old disease, I'm talking about the respiratory syncytial virus, the RSV. But in new context, usually we know RSV is the virus that affect the children and the kiddos. So, and it's the number one cause for admission in the hospital. But it's totally different talking about such a virus in another age group, which is the older adults. So the completely opposite side of the spectrum. So we're going to learn a lot of new information today based on cutting edge research and why we're going to be talking about these things. Of course, all of us as healthcare professionals, we just came out from a pretty severe winter season. Definitely the complaints and the clinic visits and the inpatient of upper respiratory infections were extremely common over the past few months. So without further ado, let's begin and jump into the next slide, please. Okay, so I'm not a GSK employee and I'm receiving an honoraria to give this presentation. Next. Okay, so first one we want to talk about is the RSV itself and its associated diseases. Associated diseases here, I'm talking about the respiratory disease that comes with that. Then after that, I'm going to talk about the cardiorespiratory diseases that comes along with that, specifically about the asthma, the COPD, and the cardiac condition, either congestive heart failure, and probably that was one of the questions we saw a few minutes ago. And the other thing is myocardial infarction. The other thing we're going to talk about what are the measures or tools that we have in order to diagnose or to treat or to prevent from RSV infection. Next. So talking about the respiratory syncytial virus, everyone have a story in his mind concerning, a patient who came with a runny nose, congestion, or cough. And you just simply say to the patient that this is a viral cause, but we usually say we don't need really to know what is the causative cause. It could be COVID or SARS-CoV-2. It could be influenza. It could be rhinovirus. It could be RSV. But RSV, it was totally away from our perception when taking care of older adults. Next. So, like all the other respiratory viruses, the RSV comes in a seasonal fashion. It's easy to be transmitted from one person to another. It's very contagious among one's household. And then, as I said earlier, and as everyone knows, it get transmitted through the inhalation of contact with infected people. It may at least cause an infection with a mean basic reproduction of 3. But for the older adults, they take longer time in terms of shedding the virus into other people around them. The seasonality of the virus, of the RSV, it happens in the same fashion that we see with other viruses for the respiratory system, like the influenza, since the Kingdom of Saudi Arabia in a temperate area. So usually we start noticing an increase in these viruses in October and peaks in January and starts going to as a slope down in February, then to March. And as Dr. Ashraf Amir mentioned, having Al Umrah season and a lot of people coming to the kingdom, we've seen a lot of cases, especially in the Western region, of different kind of viruses and upper respiratory symptoms. Of course, the normal RSV seasonality was disrupted during the lockdown and the pandemic because of the social distancing and wearing masks. But of course, as we all know, when the lockdown was lifted out, there was a surge of influenza and RSV cases that happens in the world. Next. So again, we all know RSV as the virus that affects the children, and it's the leading cause for hospitalization. So, and there's a lot of theories about that. Some of them that says that young children, neonates, infants, they have a very narrow air pipes, and so the virus can cause a lot of secretions, leading to the hypoxemia and being admitted to the hospital. But it is believed that almost all children under the age of 2 will get contact with the virus by that point of time. But as we get older and older, we do get the tendency to be in contact with the virus without witnessing any symptoms of it, so it doesn't affect us that much. Or maybe there is some symptoms, but these symptoms usually are short-lived. But the new thought now, based on a lot of research, they looked into the global perspective and the perspective in the North America and Europe with the RSV. How common is it among the upper, um, among the other respiratory viruses in older adults? Older adults seems to be also getting affected by the RSV and actually showing very severe symptoms. Next, please. So, as we all know, RSV will show the same way like influenza or SARS-CoV-2. So runny nose, congestion, and sore throat sometime. But for the older adults, it may affect their lungs as a lower respiratory tract infection, pneumonia. It may exacerbate some of the pre-existing conditions of asthma and COPD. And for those patients who are unfortunate to have a cardiac condition, it may exacerbate their conditions, leading to a hospitalization and death in some cases. Next. So there's a number of risk factors here. The number one risk factors when we talk about RSV as a new topic in older adults, according to the Ministry of Health in Saudi Arabia, a patient is considered a geriatric patient when they hit the milestone of age 60 and above. They can be enrolled in geriatric services or clinics. So the number one non-modifiable risk factor is the age here. Number two is the comorbidities. Well, based on the research, seems like chronic disease like type 2 diabetes, hypertension, dyslipidemia, COPD, asthma, and congestive heart failure do take a toll in the immune system beside the age, since patients usually go through what we call the immunosenescence process, which is immunosenescence is the natural decline of the immune system. So all these things together make older adults very vulnerable against the RSV. Next. Okay, so data from the US, we have a data that was published, the National Foundation for Infectious Disease in 2022, and they looked into as comparison between RSV in children and older adults. Again, RSV is the leading is the leading cause for hospitalization in infants, but it is leading for, it's one of the major causes for hospitalization and mortality in older adults. In the left side, we see the data concerning the pediatric age, getting the RSV. In the right side is geriatric age. Apparently, the RSV caused 58,000 hospitalization among children getting hit by the RSV, and it led to 100 to 500 deaths in US, while among the older adults population, it led to 177,000, and the death rate was, or number was 14,000. Next, please. Okay, so what is the burden estimated in older adults in the industrialized country? Here we're talking about the North America, Europe, Asia Pacific region. So according to data that was published by Savik et al. In the influenza and other respiratory viruses in the year 2023, it seems to be that the incidence of the RSV is 1.62% of all the viruses causing the upper respiratory symptoms, which is around 5.2 million. And then as an RSV, like a unique RSV, acute respiratory infections, That led to a hospitalization of 0.15%, which is around 470,000 hospitalization. And after that, the fatality rate was around 7.13%, which is around 33,000. And that was based on the data of meta-analyses that was conducted in all these different countries. Next. Okay, so we're going to dive into a lot of data from different researchers from different parts of the world. This is data that was published by Lee et al. In the Clinical Infectious Diseases in the year 2013, which showed that a retrospective cohort study of hospitalized adults. And here they looked into patients who live in Hong Kong and they had RSV. What is the aftermath when they get the infection? Apparently that within the inclusion criteria of that study, they made sure that those patients might have one comorbidity or more at least, and 35% of them, they had a pre-existing pulmonary conditions, either COPD or asthma or others. And when we look at the data, seems to be like that the outcome, the all-cause mortality rate within 30 days having at the age of 60 and having an RSV being admitted to the hospital, it was 9.1%, which is equal to 55. And within 60 days, it increased up to 72 patients. While the direct cause of death was pneumonia is the number one, then the COPD exacerbation, then the acute cardiovascular events. After that, 11.1% of patients did require intubation and being on a ventilatory support, and the majority of them required oxygen supplementation. The other problem is the length of stay in the hospital, which was at the mean of 12 days. Next. Okay, so we looked into different data. How does the virus affect the older adults being with comorbidities, different setting? But how about comparing a virus with a virus? And here we're talking about the RSV versus influenza. Which one is worse for older adults? And according to the Maggie et al. Study that was published in Vaccines in 2022, they looked in plus Ackerson, they looked in these data, and apparently that the outcomes in older adults who were age 60 and above being hospitalized in the United States with influenza versus RSV, if you can see here in the odds ratio line at the bottom, you can see that more likely with RSV with an arrow pointing to the right side and the influenza to the left side. And seems to be that the hospital utilization with the RSV was even more and higher than being infected with influenza with the age of 60 and above. And even the length of stay was longer at an odds ratio of 1.5. Plus, at the same time, seems like that the respiratory outcomes of either pneumonia diagnosis, which was the highest of 2.7, plus again, COPD exacerbation here and asthma exacerbation. Seems that RSV would increase the all-cause mortality even in comparison to the influenza with a 1.4. And even if the patient gets discharged from the hospital and they require home healthcare services after that for rehabilitation again. Next, please. Okay, so what is the long-term impact? And this is very important for me as a family physician and a geriatrician, because as a geriatrician, I have two goals for my patient. The first one is to be independent as long as possible. The other thing is I want their quality of life to be maintained as long as possible too. When we look at the graph in the left, it was based on a study that was conducted in New York State in the United States from the year 2017 up to the year 2020. And here we can see that pre-hospitalization patient level of status, how much they can do on their own, how much was it. Then when they get hit with the RSV, then admitted to the hospital, then being discharged from the hospital, even 6 months after being discharged from the hospital, those patients showed an acute functional decline with approximately one-third demonstrating a persistent decline at 6 months post-discharge. And for me as a geriatrician, this is very significant. It do reflect the overall ability of the patient to perform and the need for having a caregiver or a helper to assist with the basic activity of daily living. And as we all know, this is very costly, actually. And the other side, we can see that up to 24.5% of patients did require professional home care, up to 26.6% required readmission within 3 months post-discharge. Next, please. Okay, other than the how much they can do, the quality of life. Of course, being in a hospital for an older adults or just having acute illness rather than going to the hospital, rather than being admitted to an ICU, all these things will impair and impact the quality of life big time, because usually the recovery that comes after that will be of a very difficult journey for the patient and the family too. So it did have a role in limitation due to physical health. It did have a limitation of emotional problem, vitality, social functioning to all those patients. So even though with the short or term quality of life measures, it was very bad for the older adults population. Next, please. Okay, as Dr. Ashraf Amir mentioned at the beginning, you want to provide high quality services at the lowest amount of expenditure in the healthcare system. It is estimated that, according to a recent study, that the outcomes associated with RSV on the US healthcare system in terms of expenditure is between 1.5 up to $2.99 billion. And a couple of months ago, Dr. Abdullah Asiri also published a study that looked into that based on some of the models that was applied and looking into how much can these respiratory viruses, either SARS-CoV-2 or influenza or the RSV, can cause the healthcare system in Saudi Arabia. And for all these different kind of viruses, it costs us a lot, including the RSV, big time. Next, please. Okay, so I just talked about the basic. Let's dive into more clinical data on talking about how can the RSV in an older adult with a pre-existing condition or a lot of comorbidities, like, again, COPD, asthma, or congestive heart failure can affect those patients. Next, please. Okay, so let's take the respiratory system first. So we have two major conditions, the COPD and the asthma. Based on a lot of studies, the last one probably was published in 2019 in by Adeli et al. In the Family Medicine Journal 2019, looked into these data, and it showed that for patients who have COPD plus being infected with RSV, if they had longer hospitalization, more than usual, than patient with influenza. It did cause an accelerated lung function decline based on the measurement of the pulmonary function test. Those patients had a greater hypoxemia and a greater airway inflammation. While on the other hand, patients with asthma, 6 years old and above, and having an RSV, that led to hospital admissions, ER visits, enhanced responsiveness to allergens will be more with an altered antiviral immune response in asthmatic patients. Next, please. Okay, RSV infection can exacerbate both COPD and asthma, and that could be one of the leading reasons for the patient to be admitted to the hospital. So the RSV has been detected in 10% of the COPD exacerbation in older adults. So, but of course, there is other causes of other viruses that we will look into, but RSV was confirmed in 10% of the cases. leading for a hospitalization COPD exacerbation. And in a prospective study, including a subcohort of 1,388 hospitalized patients, RSV accounted for 11.4% of hospitalization for the COPD, while 7.2% for hospitalization asthma patients. And among adults aged 18 and above being hospitalized with RSV and acute respiratory illness across 12 countries. So as a meta-analysis, 26% had a COPD exacerbation, and 13% of them had an asthma exacerbation too, even though they were like, some of them were less than 60 years old. Next, please. Okay, so this is the what I was talking about. So for those patients, I'm not sure if you can all hear my voice if there's a noise. So for those patients who had a COPD and they had an exacerbation, they did isolate different kind of viruses out of them. And it seems that if you look at the graph in the left, the influenza was ranked third among three different viruses, which is the RSV and the rhino/enterovirus. The number one was the rhinoenterovirus, then the second one was the RSV, while influenza, surprisingly, was the third virus that may cause for COPD exacerbation. And so admission to the hospital, and that was based on a systemic review and based on pool data, different studies with a very large number of patients of 1,728, if I'm not mistaken. Next, please. Okay, so other than that, I love the contrast between geriatrics and pediatrics. I always say that geriatrics is like pediatrics with some differences, of course. So in geriatric population, we have a very long list of conditions in the past medical history list, while in pediatrics, it's almost zero. So the more comorbidities the patient have, and being 60 and above, the more chances that the RSV will lead to worsening of the general condition, leading to a hospitalization. So if you look at the right side in the box, and this is probably one of the important questions also to help you answers the survey, hopefully after that. So we have, if the patient have asthma, COPD, coronary artery disease, or CHF for diabetes, you can see that the incidence rate ratio will increase. So it will doubles the patient have any of these conditions. So for the asthma will be from 2 folds up to 3.5 folds. If COPD 3.5 up to 13.5, which is pretty significant, and so forth. So those patients, and as you see in the graph in the left side, the blotted graph. So as they get older, the chance of incident of RSV associated hospitalization will increase. And of course, that the frailty component plays a big time, and that too. So being frail, old, immunosenescence, and having a lot of comorbidities or in your past medical history will unfortunately make the patient vulnerable and going through all that. Next, please. Okay, other comorbidities among patients who are 60 and above being hospitalized with RSV. And here we're looking at the data from the Kaiser Permanente at the Southern California at USA. Here they pulled the data. The Kaiser Permanente is a very large network of hospitals and clinics. They do their own research, and sometimes they publish their own guidelines because they have very solid data and they're pretty much into it. So when they looked into the pool of patients that they have, patients that being admitted with RSV, seems to be like patients with congestive heart failure led to being admitted to the hospital, diabetes, COPD, asthmatic heart disease, asthma. So there was pretty like big percentage of those patients being admitted to the hospital because of these comorbidities. So what about patients having different comorbidities at the same time? Next, please. Okay, we talked about that there is a continuous pulmonary function test decline based on the forced expiratory volume of in the first second for the patient with the COPD. So they followed patients group of 74 in a prospective study, evaluated the consequences of RSV resistance in adults with COPD over 2 years. And here in the graph, we can see that there's a pretty continuous declining slope because of that as they follow those patients, showing a decline with higher inflammatory parameters in patients with stable COPD. If you don't mind, just give me a second because I have a background noise and I'm just want to ask them to stop it. Thank you. Give me a second.
Okay, sure.
Okay, thank you very much.
Bye-bye.
To the next, please. Okay, so this is in summary about the asthma and the COPD and the congestive heart failure. We're gonna dive more into the cardiac condition, other cardiac conditions now. So, but in summary, for the respiratory conditions, older adults with COPD and asthma are at increased risk for severe respiratory syncytial virus. High proportions of older adults hospitalized with RSV experience COPD and asthma exacerbations. There is a persistent RSV infection is associated with decline in lung function and high airway inflammation in patients with COPD. Next, please. Okay, let's look into the cardiovascular diseases. So here we're going to talk about the congestive heart failure, which you all been asked about in the pre-lecture survey. So people with chronic congestive heart diseases or cardiovascular disease are increased risk for severe outcomes if they contract the RSV and being 60 and above, like such as congestive heart failure, myocardial ischemia, infarctions, or even atrial fibrillations. That will lead for long-term morbidity and mortality for them. Next, please. So, and the pathogenicity and the sense out of that is that if the patient have a pre-existing vulnerability or vulnerable plaques on the coronary artery disease because of the fatty deposits or high blood pressure and all the other risk factors like diabetes, that will lead to the plaque rupture and so the thrombosis to happen. So the inflammatory responses that may lead to disruption and the rupture of the arterial plaques are increased if the patient contract the RSV. So RSV itself can lead to this cascade of pro-inflammatory cytokines leading to these events to happen. Next, please. Okay, so cardiovascular complications occurs, this is very important percentage here. It occurs in 14 to 22 of adults who are 18 and above hospitalized with RSV. It can exacerbate heart failure, arrhythmias, myocardial infarctions. But in a study that was done in the US, looked into hospitalization, more patients with RSV than influenza. So this is a very important piece of information here. Those patients with RSV were 29.5% comparison to the influenza patient 27.7, with a p-value of less than 0.05. Okay, so the incidence of hospitalization for acute MI in the first 7 days seems to be in the influenza arm of 6.05 and RSV 3.51, and other viruses can contribute that based on the incidence ratio. Next, please. Okay, how about RSV and influenza in terms of causing myocardial infarction in older adults, and how much is the risk can be increased because of that? If we look in the left, we can see that in the plotted chart here, we can see that over the years, it's been monitored how can influenza and RSV can cause the increase. But we can see a very clear correlation between the number of years and the weekly excess myocardial infarction admissions while having the estimation of the other all admissions and the RSV number of cases. Well, on the right side, you can see also that the weekly excessive myocardial admissions in comparison to the weekly observed myocardial admissions were different in the influenza. Next. Okay, how about chronic heart diseases and respiratory syncytial viruses associated with hospitalization? Apparently, there's a very high proportion of adults being hospitalized with chronic heart diseases. Again, here we talk about all different kinds of diseases. It seems to be that there is a pretty clear distinction when a person is a category of older adults or being less than 60 or 65. Those patients, of course, they may have the exacerbation, but we can see the pretty distinctive 8 times increase of being admitted to the hospital and having congestive heart failure symptoms in patients who are 65 and older, having respiratory syncytial virus. Next, please. Okay, at the end, we have the estimated survival during the year following the hospitalization with an RSV with a is poorer among older adults with congestive heart failure. And here, when we look at the data, we can see that those with congestive heart failure exacerbation, of course, there is the one with no baseline of congestive heart failure having the black line. Then we have the one with a baseline with no exacerbation. And the blue line coming down all the way here shows the baseline with exacerbation. It seems to be like the conclusion that we reach is that within 1 year of survival, the estimated survival rate among those patients being discharged from the hospital after being admitted with RSV cardiac conditions seems to be decreasing and affecting the long-term survival in comparison to other patients with either no baseline or baseline but with no exacerbation. Next, please. So in summary, for older adults with RSV and pre-existing condition of a cardiac problem, seems that RSV may cause cardiovascular complications in older adults, including the congestive heart failure, atrial fibrillation, or myocardial infarction. Seems like older adults with congestive heart failure or coronary heart disease are increased risk of RSV-associated hospitalization than those with no prior diagnosis of CHF or being at a good baseline. And 1 year survival rates following hospitalization with RSV and having congestive heart failure, they have a very poorer outcome after being discharged from the hospital. Next, please. Okay, how we diagnose RSV? Well, and how can we manage it or prevent it? If you could go to the next slide, we can see, of course, we don't have like a specific set that is widely distributed. It's always pretty difficult to pick the RSV unless you are in a very good center to do that. But to my knowledge, we're starting to rolling new kits out there that it's available in the primary healthcare sector, and RSV seems to be getting rolled as one of the viruses that will be under surveillance and followed in the upcoming years in Saudi Arabia. If you go on to the next slide, please. So worldwide, again, it's not a usual routine thing that we do, but at the same time, because you're gonna need some special kit to do that. Again, this is something that some of the primary healthcare centers and the hospitals, they will start to have in terms of the kits that test for the SARS-CoV, influenza, and the respiratory syncytial virus, so we can have the virus under surveillance in Saudi Arabia. especially with the large number of people coming in for Umrah and coming also for Hajj. But these measures, as they get being implemented, we're very pleased and happy to have new solutions to add it under our portfolio of older adults vaccination. If you go to the next slide. Okay, in terms of the management, as we all know, for viruses, we're just gonna give the supportive measures to help the patient in terms of, controlling their symptoms. And even though this will require us, to dispense medications, give prescriptions, and sometimes it's work, other times it doesn't. It can affect the ability of some of the patients. If they're like 16 and continuing to work, it will affect their performance. But at the same time, in older adults, we have pretty significant limitation in terms of the medication that we can prescribe that can help with the coughing. If those medicines contain pseudoephedrine, diphenhydramine, or all these different kind of pharmacological combination, unfortunately, they must suffer from side effects of delirium or confusion because of that. That's why there is another new solution that being proposed and being approved by the Saudi FDA and the Ministry of Health, which is the vaccination. Next, please. Okay, so let's talk a little bit about the vaccination. If you go to the next slide, if you don't mind. So the proposal that was recently approved. Next, please. So the vaccine that was recently approved and introduced, it have two components. The first one, the adjuvant system. And this adjuvant system is very similar to the adjuvant system that we use actually and introduce to our patient in terms of prevention from the herpes zoster. This is the same adjuvant system here, which is the ASO 1E. The other component is very specific for the respiratory syncytial virus, which is the respiratory syncytial perfusion F protein antigen of 120 microgram. The idea of creating a vaccine against the respiratory syncytial virus is not new. The world been trying to create a vaccine since the 1950s, but at the beginning of that time, it failed miserably until Dr. Henry Matthew, a few years ago, he was able to freeze that F protein portion that helped to create the vaccine after that. Next slide, please. So having two of these components, the first one is the part of the virus itself. The other one is, as we all know, that the immunosenescence process and the immune system is getting weaker and weaker, less number of B cells and T cells and antibodies. You have this adjuvant system to go along with the virus protein in order to give the immunogenicity that you would desire in those elderly patients. So pivotal study that was done, a phase 3 trial, which was randomized, placebo-controlled, multi-country study to determine how efficacious is the vaccine in older adults of 6 years and above. Next, please. So if you look at the first thing in the left, they collected data and had around 25,040 patients, around like almost like 60 of those patients were excluded from a study for different reasons. But they have randomized the patient in two arms, the placebo arm and the vaccine arm. So the vaccine arm will be the one in the purple color. So those patients received the first dose of the RSV virus vaccine that was designed for the older adults. And when they introduced the vaccine, it was in May of 2021. Those patients were followed in a seasonal fashion to see if those patients will get infected with the RSV or not. So they followed both arms, the placebo arm and the arm that received the vaccine. It seems like in the first season, the efficacy of the vaccine was extremely significant, up to 93%. We will see in the next slide. But as they continued, they followed those patients again in the year of 2022, 2023 season, winter season. But what they did is that they continued wondering whether do we need to give the vaccine in a yearly fashion in order to prevent patients who are 60 and above from RSV, or what the dose that received last year in the season of 2021 was enough or not. So they continued following on the patients in over 2 seasons, and the data was published on the New England Journal of Medicine in April 2022 and in 2023. Next, please. So the endpoint, the primary objective from the study was to see if the vaccine is effective or not. So the first season analysis in that year, first time they did the analysis in the year 2022, it did demonstrate that the vaccine provide a high and consistent efficacy against the full spectrum of RSV. RSV is not just a single type, it have different types, but the vaccine did provide the needed protection. So it prevented the lower respiratory tract disease in 82% of the patients. The severe RSV, lower respiratory tract diseases was eliminated in 94% of the patients. And in patients who have one comorbidity or more, they prevented the RSV-related lower respiratory symptoms in 94.6% of the patients. And if some of the people were wondering, okay, how about the older adults? Like the 70, 79 seems to be work wonderfully with those patients too. And that was on the one dose of the vaccine was needed to achieve all these percentages. So, and when they did the revaccination after 12 months, it does not appear to confer additional efficacy benefit to the overall population. So how about the safety? Was there any side effects? There was all the side effects that usually we see with all different kinds of vaccines seems to be appeared, like the generalized ache, some fever in the first couple of days, some tenderness and swelling in the site of an injection. Most solicited reactions were of mild to moderate intensity, but of course, you probably, as the vaccine being administered, we will continue following on those side effects and see if there is anything unusual that may happen. Next, please. Okay, so the immune response seems to be doing okay. The most common question that you may face is that by the patients, two questions actually. Do we need to take a booster for this vaccine? And the answer for now is no. So one dose is good at least for 2 seasons, 2 winter seasons in Saudi Arabia. The other thing, can we administer the vaccine with other like respiratory viruses vaccines like the influenza or the of different kind, either the high dose, which is designed for the geriatric, but maybe we don't have here, but is it okay to administer with the quadrivalent flu vaccine? And the answer is yes, you can administer the RSV vaccine along with the influenza, either the quadrivalent or the high dose, inshallah, when if it gets available. So if you can go to the next, I think that this concludes everything about this lecture. Sorry for taking such a long time, but hopefully it was beneficial for everyone. Thank you all.
Thank you so much, Dr. Tarat, for this wonderful presentation. You have highlighted the whole issues regarding the RSV infection, the population at risk with a special focus on the elderly populations, as well as the remedy of protections at the end by highlighting the features of the vaccine, the efficacy, the safety, and tolerability as well. So with this, I would like to thank you on behalf of all the audience. And I would like to start now the Q&A session, and then we will move to the post-test results. So before that, I would like to welcome Dr. Mohammed Thinian. Again, Dr. Mohammed Thinian, he was, and thank you so much for being with us here, Dr. Mohammed. Dr. Mohammed is a preventive medicine specialist, and he holds a degree from University of Michigan, part of the national EPI team since 2016, and managing the national vaccinations coverage unit. And we are taking the opportunity to ask Dr. Mohammed the good news that we have heard that المملكة العربية السعودية كانت خامس دولة تدرج اللقاح على مستوى العالم، وهذه يمكن مفخرة لنا كلنا جميعا أنه عندنا حراك لوقاية المجتمع وحماية الفرد. وايضا صرح سعاده وكيل وزاره الصحه المساعد للصحه الوقائيه الدكتور عبد الله العسيري انه اللقاح متوفر واصبح الان في متناول كل المعرضين للخطر، بالذات الفئه اللي هم اكثر من 60 سنه. ابغى تعليقك دكتور محمد if you don't mind please. Thank you so much.
مساء الخير، يعطيكم العافية جميعا. First of all, thank you for attending this session. At this time, I know it's the weekend coming up, and people are looking to have some free time and joy. But yeah, thank you so much for attending. Thank you, Dr. Ashraf, Dr. Tarad. It was a very wonderful presentation to inform our healthcare workers about the vaccine and the burden of the disease. So yeah, vaccination and preventive medicine is part of the Vision 2030. So there is two points in the Vision 2030. So the first point is improving the preventive aspect of health, of the health system. And as we know, vaccines is a huge part of preventive medicine. So there is a huge focus on vaccines in general, and trying to introduce the most effective types of vaccine that are affecting our population. There is even the establishment of the adult immunization unit at the Ministry of Health. So we are moving not just to protect children, as most countries have, as well as to initiate and cover most of the population. Out of my experience and talking with colleagues globally, the establishment of adult immunization unit and schedule is tedious. It's not easy, and alhamdulillah, we are doing so great in Saudi Arabia, introducing HPV, RSV, the herpes zoster vaccine. It means that we have good leaders, good people who's thinking about the whole population.
Thank you, Dr. Mohammed. And this is reinforced the concept that we are focusing on the well-being of our populations and our patients. And we are moving from intervention to prevention, from disease to health, and from illness to wellness, reinforcing the concept of wellness, which is a complete state of physical, mental, social, and spiritual well-being, and not merely the absence of disease or infirmity. And this has been highlighted by the good moves by the decision makers to invest in vaccinations and to protect the specific populations at risk. So thank you so much. I would like just to inform our audience just to scan the QR, and they will take your own time to answer the questions again. By the time we will start our Q&A sessions, and then we'll be back again to answer the questions. So Dr. Tarad, there is a question. You know that we are living in a season now, and Dr. Mohammed knows the same. We have a lot of upper respiratory tract infections. While I'm sitting in the clinic, I cannot differentiate between what infection is, what, there is a sound, excuse me. Excuse me, Dr. Miss Hanan, Miss Hanan, Miss Hanan, excuse me. Can you mute yourself, please? Okay, so so regarding the difference between the RSV, influenza, and the COVID from the symptomatology point of view, if I'm primary care and patient coming to me with upper respiratory tract, it could be one of these three. So how, from the symptomatology and clinical part of, is it possible to differentiate?
Well, so honestly, it's very difficult to differentiate what could be the reason, unless if you know from the history of the patient, if the patient report that they have a positive sick contact, and this positive sick contact went to a healthcare center, and they did the test for him, and they told him that he had that specific virus. Other than that, it's extremely difficult to differentiate between different viruses since they cause the same symptomatology. And so, of course, I mean, even for patients who receive the influenza virus, of course, there's still a chance for them to contract the influenza and show the symptoms. Vaccines don't protect 100%, of course, as we all know. So that chance is there. So if someone took the flu vaccine, they cannot still eliminate the possibility. The RSV vaccine seems to be showing good results in terms of the efficacy of presenting the severe illnesses and showing symptoms of disease of 94 and 93%.
Okay.
So it's
well, we know, Dr. Tarad, that the RSV labs are not done in the outpatient commonly because it's highly specific in certain centers where they have the facilities and the logistics. So why it is important to do the labs while finally we are treating the symptoms rather than the disease itself, because there is no specific treatment. And the second thing, do we use any antiviral medications, you know, to treat the RSV infections? Any recommended antivirus?
Yeah, so there is no specific antiviral treatment that we can provide against. So if you have a patient that was diagnosed, you know this patient was diagnosed with RSV. Historically, we would test for different kind of viruses. If the patient get admitted to the ICU, that's when we include the RSV as one of the viruses in the panel. But even if you diagnose the patient with RSV, there's no specific antiviral treatment that you can give to the patient other than supportive measures and treat secondary bacterial infection. But what is the benefit of, let's say that the testing is widely available in all different kind of primary healthcare centers and the emergency room? The benefit of that for the older adults, or for the pediatrics is that you can provide those patients with clear instructions, and you can counsel them and educate them about some of the symptoms and what they can do in terms of isolation. This is very important to the patient and the family. So if someone have a positive RSV virus, they need to keep that patient away from the older adults with COPD, with asthma, with congestive heart failure, to prevent those patients from, you know, being hospitalized in the hospital. And even if the patient, older adults, didn't get the vaccine and have the RSV, at least you can have a prognosis for this patient. And based on the different factors that they have on comorbidities, maybe you can have the patient in your watch list for لا قدر الله possible admission for COPD exacerbation, asthma, or CHF. So those patients definitely will be under your radar and so forth.
Thank you so much for your answer. It's elegant answer, Dr. Tarad. Dr. Mohammed, from your own expertise, how do you forecast the RSV vaccine, its acceptability by the population at risk? This is one. And the other one is, although there is a recommendation from Ministry of Health to have this vaccine, but it was not yet included in the national immunization programs or schedule for the adults. When do you think this will be applied?
Actually, it's a matter actually of so we just provided the vaccines available at a certain primary health centers and otherwise throughout the Kingdom of Saudi Arabia. So we're just piloting this patch, let's say, and seeing how's the uptake and how much is the healthcare workers or especially doctors are recommending this age group for getting the vaccine. There will be health promotion campaigns within these centers. So it will be added actually. It's just a matter of printing it out and adding it. There is no hesitancy in adding the vaccine. We're just looking at how is the uptake from this batch, and based on that uptake, we're moving to expand and the availability as much as the amount of the vaccine we purchased from JSK actually. And the campaign actually, it's not a period. It will include the whole adult immunization schedule, health promotion, and what started it is actually RSV. So the decision made was to expand and include all the adult immunization. So there is a lot of talks and discussion concerning adult immunization. We're doing, I think, we just had a meeting actually with some experts yesterday from the US and Canada, and we're ahead of time actually in concerning adult immunization and including all of these vaccines.
So, Dr. Muhammad, we already know that there was a very successful campaign that highlighted the importance of adult vaccination and the wonderful participation of the community, which was the herpes zoster vaccine campaign, which was there for almost 2 years. It was a very innovative type of campaign that tackled the mindset of the target population from different directions, different domains, with the full participation not only by the healthcare professionals, but also by other stakeholders like المركز السعودي للفنون والثقافة, when there was a museum for لوحة ألم في لوحة by the social media and influencers. They were participating and using the sport, for Vikings in Jeddah and Riyadh. So I think we have the tools now, and we have almost the milestones that we can step on and reach for the successful campaign again for the RSV. But again, I would like just to discuss, three of us, the vaccine hesitancy, because we are already coming out from Corona, and there was a vaccine fatigue. People get tired from having a lot of vaccinations, especially. So do you think that this is going to be a problem to be tackled again with RSV, the hesitancy? And if so,
hesitancy, hesitancy, if I may, hesitancy rates spiked so badly actually globally after the pandemic. It affected, surprisingly, although globally actually there is different factors to increase in vaccine hesitancy. Papers and research happened and after the Spanish flu, for example. So after each and every actually pandemic, there is an increase in hesitancy. In Saudi Arabia, I think the hesitancy unfortunately happened to be on parallel with the idea of expanding to include the adult immunization. Pediatric immunization, I didn't see actually a huge effect. I cannot deny there is a low rate of uptake even in the pediatric immunization, but it's not a huge that I would say it's concerning. Since in Saudi Arabia, the uptake is on average about all vaccines, including pediatrics, is around 95% of the target population. So that's a huge number actually, since the required is usually 85, and by the recommendation of WHO and CDC. So the hesitancy is a huge thing that should be tackled. I'm actually talking with different stakeholders to measure the hesitancy by having surveys, whether in clinics or even with some community-based organization to see how people are accepting, especially new vaccines and vaccines that it is for adults. So I'm hoping within this year to have couple of research and numbers concerning the hesitancy that we can, based on these numbers and research and epidemiological analysis, we can modify our health promotion and health education actually, because sometimes the problems are we cannot just blame the community. We should even discuss with our own self with healthcare workers. Some of them are simply not aware about vaccines. It's so such things are affecting. So we need to measure it and be our decision should be based on evidence and analysis.
Well said, Dr. Mohammed. And I think, to tackle the vaccine hesitancy, we have to reinforce the vaccine recommendation by the healthcare providers. And I think, from my limited experience, I think the counseling for vaccine hesitancy is not yet well perceived. We did not provide some training courses, for primary care physicians to counsel patients with the vaccine hesitancy, not only primary care physician, but also all the spectrum of different specialties, because the encounter of that particular patient at risk with any specialty is a precious encounter. It should not be missed. And everyone should spend a lot of efforts and maximum effort to get this particular patient getting the vaccine. So having this kind of skills and communications, this will solve. The other part is the decision makers, of course, the availability of the vaccine in the adult vaccination schedule, the pricing, and even the insurance companies coverage. This is one of the big problems in private sectors, and the availability of the vaccines throughout the spectrum of the year, and reaching for those people at risk at home rather than anticipating their own, they come to us, by their own. So we have to be proactive and deliver it at home, and so forth.
Yes, totally.
Yeah. Dr. Talat, any thoughts on this?
So, well, if you would ask the people and the patients, it was very rough years, the past 4 years, honestly, on everyone. And, with the information that we're getting flooded with over social media, especially with the older adults, they would believe chopping garlic and onion, mixing that together over listening to a doctor, honestly. And so we need to sit with them. We need to talk to them. We need to tell them it's okay to take an onion with garlic while taking the vaccine, honestly. We need to just speak plainly and simply with them, hear their concerns. The people in Saudi Arabia, they still have very high level of credibility for the Ministry of Health. The Ministry of Health have a very high level of confidence in the ministry, and the Ministry of Health have a very high level of credibility in the mind of the patients and the people in Saudi Arabia. Older adults will be affected here, and honestly, the one who is taking the healthcare decisions for the older adults are the sons and daughters, and we need to go directly to the customers and older adults. In Saudi Arabia, their percentage now is small, but we are a young population. We had our fair share of baby boomers. So in the future, This young population will get older and older, and we can approach 5% of the population. It would be easier than approaching the younger population. Research, sitting with the patients, the older adults population, convincing them, setting examples, talking to them directly, giving the respect to them, using decisions, making, I don't know, I wouldn't use the word socially engineered broadcast for the older adults, but we need to talk to them. We need to hear their concerns, and from there, we're going to reach the goal of protecting them from being hospitalized in a hospital.
Thank you so much, Dr. Rab. You mentioned in your presentation, this is one of the questions that you mentioned, that congestive heart failure and COPD is all with the RSV infections usually associated with high mortality and long-term low survival rate. But how about patients with diabetes and chronic kidney disease and other chronic disease and immune-compromised patient? Are they going to have a similar risk in mortality and reduced survival rate? You're muted, doctor. You're muted.
Okay, thank you very much for the question. It's a very good question. So the question is, do patients who have other comorbidities like type 2 diabetes or chronic kidney disease, do they have the same risk? They have lesser risk than patients who have COPD, asthma, congestive heart failure, and that according to the data that we have from the Kaiser Permanente, for example. So patient with, let's say, who have dementia, they were like 12% of total patient that they were examined in the Kaiser Permanente data. The Kaiser Permanente data gave us a group analysis based on the comorbidities. Congestive heart failure was the top of 38%. Then we have the patient who have COPD, patient who have diabetes. According to the data from the Kaiser Permanente, they were at the same level as congestive heart failure. So diabetes, congestive heart failure, COPD, ischemic heart disease, asthma, those are the conditions at the top based on the data that we have from the Southern California from the year of 2011, 2015. But I don't have data on he asked about the chronic kidney disease. I don't have the data on that specifically.
Regarding the vaccine, Dr. Farad, it's a single dose. But how long is the efficacy of this dose to give protection for how long?
Okay, so up to our knowledge and based on the published studies, the vaccine is good to go for 2 seasons. And what is done is the monitoring over the efficacy of the vaccine is continuing from 1 year to another year. Of course, as we all know, the peak in the Northern Hemisphere will happen during another time in the Southern Hemisphere. So the data is still rolling and coming to see for how many seasons, I would say, the vaccine will be maintained as efficacious, and we will see from there. Is it like gonna be 3 years, 4 years, 5 years? We wouldn't know until we see more data on that in publications.
How about the combination? This is a common question, practically a combination with other vaccines on the same time.
Well,
We follow the same rule?
Yeah, according to the published data right now and based on the phase 3 trial, the combination that was offered was with the influenza vaccine, the quadrivalent, either the one with the high dose one or the regular dose, usual dose. So this is the data that we have now. So how about the SARS-CoV? I think they're working with something of that, but I don't have the data in mind now, but we're pretty sure about the data of the influenza vaccine co-administration.
طيب دكتور طلعت the last question is if you just can summarize the feature of the vaccine in advice and recommendations, what would you like to say about the RSV vaccine that we have now?
So the RSV vaccine was approved by the Saudi FDA and the Ministry of Health, and said the vaccine is starting to roll into some of the primary healthcare centers. The RSV is recommended in Saudi Arabia for older adults for 60 and above. It's not just for someone who has COPD or asthma, it's for anyone who's 60 and above. The vaccine have two components, the F protein portion of the vaccine, the perfusion, and the adjuvant system. The idea of the adjuvant system is to stimulate what we know as a weak immune system in older adults, and it's only giving as a single dose.
Dr. Muhammad and Dr. Tarad, I would like you just to give a final statement of recommendations to the primary care physicians and family physicians who are sitting eagerly to learn how to implement this kind of recommendations of the vaccine in their clinical setup. So what would you like to tell them? Dr. Muhammad, تفضل.
Thank you, Doctor. Actually, adding to Dr. Tarad when he mentioned that we need to have to sit with the community, with the recipient that we're giving the vaccine. I think the idea of a parental approach with the community and recipients is that era ended. Nowadays, it's a collaboration between the health system, between decision makers, between the community organizations, such as Rufaida, for example. So it's a collaboration to build this beautiful picture. It's a collaboration and sitting down and listening to each other and reaching this goal. So our role as healthcare workers is not just to recommend the treatment or the vaccine for our patient, as much as even clearing out any hesitations, any rumors they have in their mind, especially that this is a respiratory vaccine, and it seems there is the hesitancy of respiratory vaccines is more than others actually. So it should be approaching and sitting down. I understand that it's not always feasible for the physician to talk on a length about a certain recommendation with the patient, but at least give him the sense that you're caring about him. Okay, when talking about prevention, I would like to say that we have the resources. It's always available. It's just how we present it. The صحتي application and making appointments for adult immunization is available, and it was a huge effort actually just to create the system for easy accessibility. So the appointments are available, the vaccine is available. It's now our role to approach our population.
Thank you so much. Well said, Dr. Muhammad. Dr. Tarat, your advice, your recommendations.
I want to thank you, Dr. Ashraf Amir, Dr. Muhammad Athinian, for weighing in, and I want to thank the audience the most, because my message to them is we need to educate ourselves. This is not just a total new topic for everyone attending. It's even a total new topic for me. I knew about the vaccine through attending scientific meetings over the past few months since last year. And we asked a lot of questions from different Saudi societies about the vaccines, and we looked into the data, and we are extremely happy for the vaccine to be introduced as one of the countries in the world to be lucky to have these vaccines, for especially for me as a geriatrician. And congratulations, everyone. You did the first step, which is being educated and attending this seminar. So I want to thank you all and congratulate you all for gaining some knowledge about this new vaccine in Saudi Arabia. Thank you very much.
Thank you, Dr. Tarat. Now we will go for just only 2 minutes just to answer the questions and to see the response of the audience and how they got the correct information. So, dear colleagues, ladies and gentlemen, we would like to go for the first question. Respiratory syncytial virus infections may occur in upper respiratory tract, lower respiratory tract, lower digestive tract, upper and lower respiratory tract. So we'll see the answer. Rahman, answer. Let me see the answer, please. Okay. Right. So the correct answer is upper and lower respiratory tract infections, as you know. So it's not only upper or lower, it's both. And definitely it's not the lower digestive tract. Can we get the results, Abdurrahman? Okay. So we have the result here. Yeah. Upper and lower, they are almost 50% of the audience, they answered the correct answer, but the others, they were they have the incorrect answer. So we'll go for second question. This is the pre-test, right? Next, please, Rahman.
One minute, please.
I think we will go for the answers directly. If you can put the answer, or you can put the questions, please. So we'll answer the questions now, so in order to be on time. So we answer the first questions, which is respiratory syncytial virus. Infections may occur in both upper and lower respiratory tracts. The other question is, all the following groups are at increased risk of severe illnesses due to respiratory syncytial infection, except. So definitely we have learned from Dr. Tarad that he said population at risk, they are elderly patients, especially those who are 60 years and above, and people with chronic heart disease and lung disease, like COPDs, immune-compromised patients, and it has been mentioned as well stated, but definitely not the healthy teenagers, because these are not involved. And we have seen that both spectrum of extreme age, the young populations and elderly population are at risk of having the RSV infection. After full recovery from RSV infections, most individuals cannot get reinfected. No, it's not true. So they can get the opportunity to get another infections, and here why we have to have the vaccine to give them the protection that we are looking for. The third question is incidence rate ratio for RSV hospitalization in older adults with COPD. When we compare it with healthy individuals, definitely it reached between 3.5 to 13.4%. So this is the rate of hospitalization. So it's a huge percentage of risk for hospitalization of patients with COPD. Incidence rate ratio for RSV hospitalization in older adults with congestive heart failure, how much it is? It has been stated by Dr. Tarab that it reached up to 7.6. So the answer is D, compared to the healthy individuals. So with this, ladies and gentlemen, dear colleagues, on your behalf, I would like to thank our guest speaker today, Dr. Tarab Tilmisani and Dr. Muhammad Athiniyan, for their wonderful contributions for the success of this scientific event and the wonderful discussion we have. And thank you for the quality of questions that I have received. It's really reflected the wonderful interest from you as a primary care physician and family physician. I would like to thank my colleagues in the Saudi Society for Family and Community Medicine, who are always shouldering this kind of activities and maintaining it throughout the years continuously. And this is the only way to enhance our capacity and to get the opportunity to learn more and to exchange expertise, having with us the subject matter experts invited all the time. I would like to extend my thanks to GSK company for sponsoring this event and make our gathering viable. And finally, I would like to thank ملتقى الخبرات لتنظيم المعرض والمؤتمرات for organizing this. Till we meet again, ladies and gentlemen, stay tuned, watch our advertisement for the next event. And today onward, I think with the wealth of information that we had, we can go with full confidence tomorrow onward to our clinics, identifying those patients at risk of RSV infection because it's highly contagious, highly devastated, disturb the quality of life of patients. So that's why we have to focus on our group, providing them with a highly efficacious, safe medication, safe vaccines, which is available everywhere. Luckily, alhamdulillah, we have it free of charge everywhere. So I think it's an opportunity to recommend for this vaccination. Thank you, ladies and gentlemen, and thank you all of you. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, everyone. Thank you, Dr. Rashid.
Thank you.
يعطيكم العافية دكتور محمد، دكتور طراد. Thank you. ونلتقي دائما على العلم النافع والعمل الصالح بإذن الله، بوجودكم دائما معنا.
إن شاء الله.
يلا
إن شاء الله. يعطيك العافية دكتور. أشكرك.
في أمان الله. السلام عليكم.